We have seen incremental benefits from a more interventional surgery, so removing as much of the tumour as can be safely removed. It hasn't been tested in a randomized trial, but all of the retrospective data clearly underlines that that helps. It also makes it easier for us to give subsequent therapies because if there's still a lot of tumour in the brain, there can be raised intracranial pressure, and if we start in with radiotherapy, that makes it worse. So, surgery is really important. I do want to emphasize that. In terms of non-surgical therapy, we kind of know what is the maximum dose of radiotherapy that we can give. We know that just increasing the dose of radiotherapy doesn't improve survival and possibly makes side effects worse. So I'm, again, interested in combining molecular targeted drugs with that radiation to make it more effective, both in terms of better control of the tumour, and also in more recent years we've been looking at drugs that can do that while maybe at the same time protecting the healthy brain. Because one thing to bear in mind is that in those patients who are living longer, we do see long-term toxicity in the brain. So short-term memory loss, cognitive dysfunction, which is very damaging. So yes, trying to improve tumour control and also trying to protect the healthy brain. So the sorts of drugs that we're looking at, I'm particularly interested in drugs that inhibit the DNA damage response. So we know that the only treatments in GBM that have been effective are things that damage DNA. That's how they work. So radiotherapy and temozolomide. We've got some evidence preclinically that if you inhibit repair of that DNA damage, you can kill more tumour cells and hopefully improve outcomes. So that's what I'm interested in. I'm running early phase trials with a PARP inhibitor called olaparib, also with AstraZeneca an ATM inhibitor, and we've seen so far that those combinations are well tolerated. And it's impossible to say from a phase 1 study, but some patients doing unexpectedly well. So we're going to continue that work. There's huge interest in the immune system and GBM. So just testing immune checkpoint inhibitors hasn't worked. And we know that the immune system in the brain is very different than it is in the rest of the body and a bit mysterious. No one's quite sure how it functions, and particularly when a tumour is present, we know that GBM creates a sort of profound immunosuppression around themselves, almost like as a protection against immune attack. So with better understanding of the specific immune system in the brain and around GBM, I'm hopeful that in time we'll get some therapies that can overcome that immune suppression and get longer term tumour control. But we're a little bit away from that. And maybe in the future, combining the DNA repair inhibitors with the radiation, maximizing tumour kill, maximizing the immune signal from the tumour with some kind of immune modulating therapy used afterwards for longer term control.